This week on the Back Table Podcast.
In theory, any oncologist that finishes training, we are certified to treat any kind of cancer. I venture to say, I think 99% of oncologists, unless you treat sarcoma regularly, it is not a cancer that most oncologists feel comfortable treating. And that's because the therapy is so intense. The therapy is the same kind of medications that we give to leukemia patients that stay in the hospital for 30 days. These are a lot of the same chemos. Also, knowing that we're working with so many other doctors, like working with the surgeon and working with the radiation doctor. And sometimes the surgeon needs to bring in another surgeon and then making sure you time your chemotherapy. There's just that level of organization, that level of collaboration that I think it's better to have on an oncologist that is just focused, I think, on sarcoma. You're going to give the best level of care.
Hello, everyone, and welcome to the Back Table MSK Podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the spine jack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show.
I'm Alexa Levey, an interventional radiologist from Houston, and I have the esteemed pleasure of hosting today's very special episode as your guest, discussing a multidisciplinary approach to the treatment of osseous and soft tissue sarcomas. I am joined by two close colleagues who I met over 2 years ago working in Houston in the Med Center at the very first multidisciplinary sarcoma tumor ward in Houston, and had the pleasure of sharing these two female powerhouses with you. I have Dr. Jessica Jones and Dr. Yvette Ho. Welcome to the show, guys.
Thanks for having us.
Yeah, thank you.
Dr. Yvette Ho is an orthopedic oncology surgeon, director of limb salvage surgery in the Department of Orthopedic Oncology and Sarcoma Surgery at the Carl G. Simon Cancer Center in Morristown Medical Center in New Jersey. And Dr. Jessica Jones is an associate professor of the Long School of Medicine with UT Health San Antonio and the director of cancer prevention at the Mays MD Anderson Cancer Center. So guys, why don't you guys tell me how you got involved first in your professions and then found your way into treating sarcomas? And we'll start with you, Yvette.
My route to this field was a little unusual, I guess. Actually, when I was in college, I didn't really think I was going to go into medicine, but after college, I had actually majored in East Asian studies. Who knows what I thought I was going to do with my life. But after college, I ended up getting a job. I ended up getting a job randomly doing research for what turned out to be a very eminent orthopedic oncologist. I didn't know at the time, Martin Mallower in the DC area. And I kind of fell in love with the field. And then I was like, oh no, I guess to do this, I have to go to medical school. So and I ended up getting a master's at Johns Hopkins and going to Georgetown for medical school. And I mean, honestly, when I went to medical school, I thought maybe I would find something else that would be just as interesting, but nothing really compared to orthopedic oncology for me, just the variety and learning about all the pathologies, and it just really appealed to me. So here I am now. I've gone through my residency and my fellowship, and I've been in practice now and following in Mallory's footsteps, hopefully.
And still standing up right after all that, which is great. So. Wonderful. And what about you, Dr. Jones?
So I think kind of following up with what Yvette was sharing, Dr. Ho, I think it just takes meeting the right person, somebody that you really look up to think to yourself, you know what, I want to be kind of like them one day. I am a first generation college student, and I've never once had somebody in my family that had gone beyond that, right? Nobody had gotten to college and beyond. And so when I found myself thinking about a career, I was brought to medicine, right? I wanted to go to medical school because I just so looked up to the physician who took care of my family and took care of me. And then I was fortunate enough to get into medical school and have a scholarship. I was able to get to medical school on a scholarship just as I had been in undergraduate training. And when I was there, it was realizing that this field of oncology, this world of cancer, there is so much that we don't know. We don't know why some people smoke and nothing happens to them. We don't know why some people drink and things do or don't happen to them. We don't know why somebody gets cancer. It's not their fault, even if somebody smokes, even if someone drinks. It doesn't. There are people who work in power plants. I could go on all day about this. And I think it was that unknown. It was that question that I just want to answer. That's what brought me into oncology and now getting to work with amazing people just like yourselves.
Well, thank you for those wonderful introduction, ladies. And as I said, I had the pleasure of knowing these two women and working with them the last 2-3 years and bouncing ideas off of them. And kind of piggybacking off what you said, every cancer is so different. What people don't understand, why haven't we cured cancer? It's because it's your own body cells gone wrong. And we happen to be able to subtype them, but manage them can be very challenging, particular with sarcomas. And so what are y'all's general thoughts about why sarcomas are so difficult to manage? Dr. Jones, we can start with you.
I think that in the world of cancer, it's already hard enough to wrap your head around cancer, right? Just as you said, it's irregular cells and they're growing inside the body and they took something normal and they made it abnormal. But sarcoma is particularly challenging because of where it started from. It started from these bone cells when we're talking about bone sarcomas, or it started from these very early muscle cells. And whenever you think about your bones, it's one of the most solid things about you. I'm not talking about like a liver or these other organs, right? You could really wrap your head around it, but your bone is just this strong, intense structure that you grow, and then this is it, right? Same thing with our muscles. And so these cancers, as a medical oncologist, are very hard to treat because when I give medicine, I know I need to go very deeply into this organ, this bone, or this muscle.
Yeah, and I think also on top of that too, sarcoma there's so many diagnoses, within sarcoma. I mean, no one even agrees on the actual number depending on the source.
You read my mind. Oh my God.
So it's always changing. Yeah. Well, we're talking about bone sarcoma. You think osteosarcoma, but then there's also Ewing sarcoma. Even Ewing sarcoma is not one diagnosis. Now it's a family of sarcomas. And people, I could go on all day, As for soft tissue sarcomas, I mean, the names have been changing. What used to be the most common, malignant fibrous histiocytoma is not even a diagnosis anymore. Now, so there's a lot of change, and the problem is they're also not that common. So they're so heterogeneous. We can't. I mean, people ask why haven't we figured out how to cure cancer? It's not a thing. It's many, 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 very, very varied things, right? It's even more so with sarcomas, and unfortunately, because they're relatively rare, we do tend to, in our studies so far, lump all the, especially soft tissue sarcomas, together. But we've been finding more and more over time they're not all the same, So it's been very difficult historically to kind of figure out best treatment.
100%. And these tumors are often fast growing, correct? And they metastasize. And so you really have to be very aggressive in your management. And that's why multidisciplinary care is so important.
Well said, Alexa. There are some cancers that we're going to detect because we have screening tests for them. There's some cancers that are so common that we've been able to perform scans like mammograms, or we get insurance to approve procedures like colonoscopies. There are some cancers that we're just going to be able to detect because we know, one, how to detect them, and two, what they're supposed to look like. But this isn't a cancer anybody's supposed to suspect, right? And even then, Alexa and Yvette, how many times have we sat in these tumor boards together looking at these pictures of pink and purple cells, right? That at the end of the day, it's at the level of DNA. Thank goodness we're starting to understand it better. But I mean, there's still so many different types
and all ages, young children, the elderly. It's so complex to manage. And with that, Yvette, how do these patients come to you? Do you manage soft tissue sarcomas such as desmoids as well? And do you have other surgical specialists you collaborate with? What about the osseous sarcomas?
Yeah, I will treat anything. So I guess I didn't really go into it earlier, but I'm an orthopedic oncologist. So it can be a confusing term for a lot of people. Everyone thinks orthopedics just means bones, but the reality is I do a lot of soft tissue too. So I'm an orthopedic surgeon by training, but I specialize in musculoskeletal tumors. So some people prefer the term musculoskeletal oncologist instead of orthopedic oncologist to kind of reduce the confusion. But in any case, I treat patients of all ages. I like to joke from a day to 115 years old, and I do bone, soft tissue, and pretty much anywhere in the body. Nowadays, people are so subspecialized. It can be really hard for patients sometimes when they have a tumor in a certain location that's kind of in a gray zone between two different areas. You know what I mean? Like if there's a tumor right above the collarbone, then it's kind of this this sort of like, DMZ where like head and neck is like, oh, that's too low. And thoracic surgery is like, oh, that's too high. You know what I mean? So a lot of times we end up quarterbacking those types of cases. And if we, if a tumor is creeping up in the neck, we'll engage them or, so I think that's one of the things I really like about this field is how much we get to work with all these other subspecialties.
No, I've definitely seen a couple of desmoid tumors when they're creeping into the thorax, and then you have cardiothoracic surgeons on board, or when they're creeping into the abdomen and they're very big and complex. And what if they need a heavy pelvectomy, but you also need a general surgeon, a surgical oncologist? And we've had the pleasure of also working with Dr. Casey Duncan, a fantastic, very brilliant surgeon at the University of Texas in Houston. And that multidisciplinary collaboration, along with, of course, our oncologists to shrink the tumor, we're going to touch on this a little bit more, how we combat these tumors best, really makes it so important to have good relationships with people in different fields.
I think that's part of what adds the challenge, right, of sarcoma is that you don't know unless you know. And as an oncologist, this was really surprising to me because I always just thought, I'm just the doctor that gives medicine, right? Like I feel like I have this certain role when it comes to any kind of team I'm in. But specifically with sarcoma, it's because you have to know, just like what Yvette was sharing, like, yeah, you need your musculoskeletal orthopedic, surgeon, and then they're going to work with head and neck, or they're going to work with people like yourself in interventional radiology. Like it's the fact that this isn't even straightforward surgery, right? Just like it's not straightforward medication when it comes to the oncologist. And then we're saying the word desmoid, but it makes me laugh because also, right, it's also aggressive fibromatosis. Like we don't even have the same, like there's so many different names for it. And like, there's just so much going on with sarcoma.
Very non-standardized, which is why it's so important to have talks about this. So what information about the tumor or patient is important when formulating a treatment plan for who to consult?
Yeah, if I can jump in on this one, because there are certain there are certain tumors that are going to be responsive to medications and some that aren't. I think we can all agree that sarcoma is traditionally supposed to be the one that does correspond to medication, that you think about Dr. Ho, you think about surgeons and you try to get it out. But we've known historically that just doing that alone, it doesn't seem to be enough. And so depending on the type of sarcoma, we're learning more that there's a real big value to giving medication, even up front, different kind of therapies to not only assist with the surgical outcome that Dr. Ho is going to get, but moreover, we're thinking about how do I kill the things I can't see? The scans are only picking up actual tumors, but what about the stuff? How do I stop it from coming back in the bones or the lung or the liver? It's because I need to kill things that I can't see. And that's where medication comes in. That's the whole point.
So I think something that really ties into what you're talking about is we all worked on this ChemoSense project. And do you mind just giving us a brief overview of what it is? Because if you were heading up the project. And so I know we took biopsies of different tumors and grew them somehow, and then we're able to actually determine what chemo worked best based on a person's tumor.
Right. No, so we need to move the needle with sarcoma. Okay. We all agree. We need more information. And so we were really fortunate to be a part of one of these studies where using the biopsy and me running after Yvette, going to you in the OR. And then what we're going to be able to do is we can grow these cells and make an organoid. And then we're essentially growing this person's tumor. And when we grow this tumor, what we're doing is we're testing different chemotherapies in this tumor. Now, there's some limitations to the study, right? Like, I'm just growing the tumor and I can't replicate the microenvironment. That is to say, I can't replicate your immune system. And we kind of knew that, but we're able to see in real time, which different therapies seem to have more cytotoxic activity to the tumors. And we were able to compare that from the scans after giving, I was giving the upfront chemotherapy, and see there were a few times where we saw, oh my gosh, this tumor, which because we're lumping things in these big groups, traditionally I would have probably given a drug called doxorubicin, but it looked like a different drug called gemcitabine did actually very well with it. And then, subsequently, when that patient needed more medication, I went ahead and I chose a gemcitabine-based regimen. But while it was an option anyway, I had 5 different options I could have picked from. I picked the gemcitabine option, kind of knowing that we were able to see what happened in this organoid. And yes, that patient had a wonderful response, had a great response to that therapy. And moving towards precision medicine is really important, especially, I think, in the world of sarcoma.
And I think it's so incredible. Again, personalized medicine based on your own personal tumor. And it's also very important when you're selecting a chemotherapy. Not only, of course, you want to kill everything that's bad in the patient's body, and but you want to do that with the least amount of side effects as possible. So if you change and do multiple different types of therapies, patients have side effects, patients' counts get knocked down, it will affect their future surgical treatment. It may affect their future interventional treatment based on what happens. So you being able to upfront figure out what they need is huge and massive, and it's incredible what you guys are contributing to the research in this field. With that, I'm also going to talk a little more about biopsies, because obviously Dr. Ho does biopsies and interventional radiology does biopsies. And there's this huge dogma about, call the surgeon whenever you do a biopsy. And I remember one time I was doing a biopsy and I couldn't get a hold of the surgeon and I refused to do it. And it's like, just do it, Levey, just do it. And I'm like, no, these sites, I'm going to see the track, and just, freaking out about it. I don't want to spread their cancer, And I remember when I was working, I was an attending at UT, one of the surgeons that told me, use an 18 gauge, it's okay. It's not going to be a big deal. Just go ahead and take a biopsy. Now, I know the risk of tract seeding is low, but what are your thoughts, Dr. Ho, in terms of tract seeding and biopsying? What if you can't get a hold of the surgeon for the biopsy? Is there a better, a good place to take a biopsy other than just doing it once and not sticking the patient multiple times?
Well, the traditional teaching has always been to engage the surgeon who will be performing the eventual resection so that the biopsy can be performed in line with the incision that we would use to take out the tumor. Because of what you're talking about, the seeding of the spreading cells through the little tract where you stick your needle in.
That also can happen during open biopsies too, correct?
Yeah, and in fact, the studies show that really doing open biopsies has a lot more seeding than with the needle biopsies that you do. So it's probably low risk if you do a needle biopsy, especially 18 gauge is not a huge needle. But I still think the overall feeling is that, even if it's just, 1 in 100, that there's going to be some seeding, you're probably better off still just to be safe. And we still tend to take out the biopsy tract if possible. That being said, in patients who do get pre-treatment with chemotherapy or radiation, the time from biopsy to actual surgery is so long that oftentimes you can't see the biopsy tract anymore, in which case, maybe we'll make the gesture to do it. I don't know how effective or important it is to take out the tract when they've had treatment for the tract already.
This is something I think about for you guys real quick, though, because I feel like patients ask this question all the time, right? They worry about this for every cancer, but this isn't for, that doesn't happen in breast cancer, right?
I'd imagine, honestly, if you're getting a little off track,
I know, it's sorry.
Important. No, but it's important to address. I know for renal cell carcinoma, the risk of tract seeding is less than 2%. And so initially, we would never biopsy RCCs, 2% is still not 1% or even small. And so the dogma was always to biopsy and then ablate. Or, you get an MRI, you say it's an RCC, you do a partial nephrectomy, a nephrectomy. And then if it's an oncocytoma, it's an oncocytoma, and if not. But now they have such good genetics determining whether it's a renal cell carcinoma or whether it's an oncocytoma. They can do a really good cytoreduction now. with different types of cancers before, possibly doing nephrectomy or doing a cryo. And so now I think they're moving the needle a little bit about saying, what is it worth and what is it not? And I think because, as what you're saying, Dr. Jones, is the fact that you do give chemo, and how much do we really see on imaging? People would love for me to say, like, this patient has X, Y, and Z. What do you mean you see nothing? And I'm like, I'm sorry, the magic 8-ball is not working today. We'll try again. But, imaging becomes such a big corner point of medicine, but you can never say micrometastatic disease or anything else like that. So maybe it is the chemo and radiation. And none of us want to have our feet held to the fire and say, just go do it and it's okay. None of us are saying that here, listeners, okay? But I think what we're saying is overall, the risk tends to be so low. So talk with the appropriate people if you can and make the right decision. But very good point. Obviously, all that urology knowledge is, shout out to my husband who's a urologist, Dr. Ryan Levey. He's fantastic. All right, so let's go ahead and talk about the fun stuff now. So the collaboration between the sarcoma surgeon, the surgical oncologist, the oncologist, and actually before I even get to that, an oncologist. So Dr. Jones, I know that you specialize in breast, and breast was your baby and what you love the most. And then you kind of got asked to take over sarcoma with us at your first job and had no experience with it. How was that, taking that over? How important do you think it is for an oncologist to have a lot of experience in sarcoma when they're treating sarcomas?
Yeah, so sarcoma,
any oncologist do it.
Right. Well, I think, in theory, any oncologist that finishes training, we are certified to treat any kind of cancer. But I would say I venture to say, I think 99% of oncologists, unless you treat sarcoma regularly, it is not a cancer that most oncologists feel comfortable treating. And that's because the therapy is so intense. The therapy is the same kind of medications that we give to leukemia patients that stay in the hospital for 30 days. These are a lot of the same chemos. Also, knowing that we're working with so many other doctors, like working with the surgeon and working with the radiation doctor. And sometimes the surgeon needs to bring in another surgeon, and then making sure you time your chemotherapy. There's so many moving parts to sarcoma, which I think is another reason what really attracted me to taking care of sarcoma whenever we were in Houston, because it's that level of organization, that level of collaboration that I think it's better to have on an oncologist that is just focused, I think, on sarcoma. You're going to give the best level of care. And also you're prepared for that kind of the side effect profile that you're going to be dealing with. But also, you guys, right? The surgeon also needs to know who to go to, and the radiation, oncologist, they need to know who to go to. And because we just don't have any room to make error for a sarcoma patient. There's no room. And I know we should say that for everyone, but especially for sarcoma, it's so intricate.
And Dr. Ho, we worked with you and Dr. Lador as well. And, I would say I've seen, participating in these tumor boards, there seems to be a very big difference between the general orthopedic surgeon and then the orthopedic surgical oncologist. Can you speak to that a little bit about maybe different ways you guys might manage different surgeries?
Oh, yeah, absolutely. Well, I think really the orthopedic oncologists, I always joke that we're the weirdos of orthopedic surgery, really. Most of the subspecialties are very focused on a specific anatomic location or a very specific type of surgery. And, we're the opposite. We're all over the place. We operate on everyone and all types of pathologies. I think we're relatively
resilient.
Unusual.
You're resilient. I see that as resilient.
Yes, sure, absolutely. But yeah, I wanted to comment too about the oncology difference too. I think traditionally in the past, a lot of the studies had shown that chemotherapy wasn't really that useful for sarcoma or whatever. But I think the problem is, especially in our field, in orthopedic oncology, that's surgeons, we tend to just think of chemo as a binary thing. Yes, chemo, no chemo. But the reality is, having worked with Dr. Jones, there's a huge difference in just giving someone some drugs, and then also, and then being a dedicated sarcoma oncologist like she is. I mean, the outcomes that we were getting with Dr. Jones were just phenomenal. And I've worked in multiple places before, and I mean, like she was talking about, it's very toxic therapy. And I think in the past, it wasn't really, the supportive care wasn't the same. And, people could die from their chemotherapy. And I have lost a patient before on chemotherapy elsewhere. But, Dr. Jones was so on top of everything, and she would just, her patients would be texting her and calling her, and she was just so on top of them that she was able to get them through the treatment. And it was really amazing the difference it makes. So absolutely, sarcoma oncology is completely a different field.
I love to hear that. So let's talk a little bit about the collaboration between all of us as different groups and how we kind of play a role, So for example, let's talk about soft tissue sarcomas, like a desmoid tumor. So you either do an open biopsy or IR does a needle biopsy. Usually we do chemo now first, right? Why wouldn't we jump straight to surgery? Or would IR have any role in this?
So I'm looking at you, Yvette. I'm like, you tell me, do they need that this death?
They're like, oh my gosh, these desmoids. Oh my gosh, I'm like shaking my head, just holding my head right now.
I know the poor readers. Listeners, they just need to know. Okay.
So yeah, I think like in the Musculoskeletal Tumor Society, we revisit desmoids every once in a while. They're basically the bane of our existence. Because, technically, especially if you're dealing with extremity, you think of it as a, quote, benign tumor. It's really very not benign, though.
Such a misnomer.
It's behavior.
It
exactly.
is such a misnomer.
Exactly.
Tell that to the person who's got this thing, right? Growing out of their shoulder. Please. It is not benign.
Well,
exactly.
It's not even that it's growing. It grows into other structures. It causes pain, right? It stretches. It causes deformities. It can cause obstruction as well, right? Because these things do grow pretty rapidly, but they also tend to be pretty hypovascular as well, which I think is why they're so hard to treat.
They're different than soft tissue sarcomas in that they are very invasive. Soft tissue sarcomas tend to actually grow like a ball, and they can push structures, but they're less invasive than desmoids, actually. So, yeah, everyone hesitates to even use the term benign for them because they're not technically cancer, but man, they can be really destructive.
Yeah, while I know I'm going to use the word benign because benign means it's not going to spread, it's not going to go to your liver, your lung, and shut down these organs. But at the end of the day, these, like what I've seen Yvette and remove and so on, there's a really extensive algorithm that I think the National Consortium has kind of agreed on for desmoid. And to be honest with you, it's actually watch and wait at first. But that would, I would say, be for the majority of patients that it was kind of maybe found incidentally, honestly. Because what we've seen, I think in Houston especially, there's a large community of people who just aren't proactively engaged in their own care, right, in their own health care. And so what we would see are these very large tumors that have grown. And if somebody isn't able to have surgery, well, then we would lean into medication. And so the medication that I would offer these patients, one, we were trying to, downstage, can we get them to be a surgical candidate, is actually a targeted therapy called a TKI. Traditionally, we even used to use a drug called tamoxifen, which is used in breast cancer back in the day. But, there is this role for medication. It does not always work, though, because, at the end, what medication needs to do is it needs to get absorbed into the bloodstream and it needs to get to these tumors. And sometimes, jumping back to that hypovascular, we won't see the shrinkage that we may need to see. But sometimes I wonder, it's just because it's so big, what is it going to do?
But sometimes, correct me if I'm wrong, you can get about 30% decrease in size, correct?
Yeah, they're really variable. That's the thing, is that it's so frustrating because some have reported spontaneous regression, which is why now they recommend watch and wait. It's a little difficult. It's kind of a tough sell for a patient when they have a big lump that's growing. You're like, maybe it'll go away. How long do you wait, really? And also knowing that it's pretty invasive. And so surgically, it's always a headache for us because, traditionally you think, okay, for sarcomas or desmoids, right? If you want to take it out completely with a rim of normal tissue, a margin, right? To try to get every single little cell. First of all, it's very difficult to get every little cell, get a negative margin, as we say, for a tumor that grows in a very invasive, infiltrative pattern like a desmoid. In the meantime, where is it growing? In your muscle, whatever. We have a tendency, I think, in medicine to be like, it's not your heart, not your lung, it's fine. But, tell that to the patient who's getting a huge chunk of their, deltoid, their shoulder chomped out, right? And then it can be very morbid.
And they're young, right? They're usually younger.
Yeah. And it can be deforming, you know what I mean? So, you have to consider all these things. On top of that, then they also have a high risk of coming back. Even if you do get a margin, they're just really nasty tumors.
I really want to jump in, and because whenever you were saying that deformity, that like it reminded me that there's a good portion of these patients are going to be younger women, actually. Something about estrogen and something about pregnancy too. And so you're talking to this young woman, and the medications that I would prescribe have a risk of infertility. And so you've got a 20-year-old woman who just had a baby and you need to give this medication. It's very complex. Again, kind of spinning back to, sarcoma really, it's best treated whenever it's somebody that's just going to keep treating sarcoma, because how do you answer these questions for these really complex questions? So it's really important that we also monitor fertility for these people that are getting medications. As the younger they are, especially if we're going in for cure, which is best practice. Like if we can cure somebody, if I'm going to help you live the rest of your life, I want to make sure you're going to live your best life. And so it's, I think, really important to throw that in here for everybody. We need to be more mindful of that.
Exactly right. And there's actually 2 cases I want to talk about, because some people don't realize that as IRs too, we can play a good role in desmoid tumors. My first case as a fellow was with Dr. Zachary Raku at Emory. And this was the exact patient. She was in her 40s. And she was supposed to get a tummy tuck, and they incidentally discovered this desmoid, this hard mass, other things. And she didn't want to get a surgery. Surgery, and it's not for not trying to get good margins, but there's a 50% recurrence. I think that's even with radiation, just because you don't see these margins of what's going on. And they're so difficult and challenging to manage. And they don't just shell out, as you were saying, like these nice little balls. So that was my first introduction and training was for cryoablation of these. So you place a bunch of probes, overlapping probes, single or multi-session to treat these. And it's a minimally invasive way. Now you get about 30 to 40% shrinkage of the mass, but one of the biggest symptoms that at least patients that I've seen, and I don't know about you guys, I guess when they come to see you, it's because they're so massive and they're growing into things, because otherwise people aren't, well, I guess now people can get full body scans just for funsies if they want to have an extra $2,000 lying around on a really crappy MRI.
Oh my God, we talk about that all day, different days.
Don't get me started. But the average Joe is not. And so they come in, they're already really big. And so that was my first experience. And then on the other side, I had a person come in with a 20-centimeter desmoid to our county hospital. And it had already been resected and irradiated in Mexico. It had this huge scar. And of course, as I was into attending, and I said, oh, let me try cryo. So this has already happened. And of course, did we have cryo at the community hospital? No. And this is something I will say, it's very important to have a good chief. Dr. Campbell was very big about supporting, when I was at UT Houston, getting cryoablation there for our patient. And I did 4 sessions because it was so big, because it's so important. Just like whatever your interventional radiology, just like a surgeon, you have to get a surgical margin. So getting the probes to overlap was really important. And then not doing so many probes that you get a huge inflammatory reaction. Although, truth be told, her last session was 14 probes because I was 37 weeks pregnant and my other partners didn't want to do the case. She had a little bit of inflammation afterwards, and she followed up for a year. And I mean, she had a lot of little sticks in her, but her pain was gone. And then I couldn't get her to follow up anymore. I mean, who knows if it came back, if it didn't. I mean, I would assume, again, these things are extremely aggressive, but I think that learning about multidisciplinary approaches to these things, you can resect if you worry you can't get it out. Do you do a TK inhibitor first? There's a new medicine, Dr. Jones, I want you to mention in a second. I keep forgetting the name of. That's really cool. But do you try that? Do you try surgical resection? And then do you do cryo if it comes back? Do you do cryo first? And then, and realizing that, or radiation as well. And realizing, I think the biggest thing, that all of these therapies don't prevent you necessarily from doing another. Radiation maybe because of tissue healing, but even if once, that doesn't X out cryo in the future. And I think that's the biggest thing I've learned from these tumor wards.
Yeah, I'm going to piggyback on that, Alexa, because if it wasn't for the progressive forward thinking of the interventional radiology department and your collaboration and discussions, I didn't even know cryo was an option. How could I be a doctor and a cancer doctor for these years? How could I have finished all this and not know about that? So I am so grateful.
Dr. Jones, Nobody knows what we do. You're not alone. That's why we're doing this podcast. But seriously, you guys, like, there's just so many developments in medicine and nobody can know everything. So everyone, I think, in medicine needs to like take a little bit of a humble pill and recognize that they need to work with everybody else, because that's why we have specialties, so we can become specialists in our field. And there are other people who are specialists in their field. And we can just work together just to provide the best possible care for our patients.
Which is a great segue to bring in that new drug that Alexa was trying that we were chatting. So Dr. Levey, thank you for asking. My gosh, there are so many. There's been more drug approvals from the FDA in the last few years than we had seen ever before. And so just in 2023, there was a new drug specifically for desmoid, i.e. aggressive fibromatosis. And I say that because sometimes, insurance-wise, you got to label things in some kind of way. But in any case, it's actually a gamma inhibitor, gamma secretase inhibitor, and it's called nirogacesta, and its brand name is Ogsiveo. And so this drug, it actually is another way, and it seems to have, in what I've been able to see, very successful shrinkage of this tumor in ways that I wasn't seeing TKIs do. But of course, there's going to be side effects, and there's going to be different parameters I'm going to need to monitor closely. And the most important parameter to monitor is fertility. It actually made 50% of the patients infertile. And so doing, especially for women, ovarian suppression, like protecting her ovaries while she gets this medication. It was initially approved for patients that were not surgical candidates, but what we were able to see is that in the patients that were getting this drug, it shrunk the tumor, and sometimes it was totally resolved. But in any case, like shrinking the tumor to where you could bridge them to become a surgical candidate.
Ovarian suppression, in terms of that, do you mean these people, maybe can they freeze their eggs and will their function return once they're off the medication so that if they want a child in the future, they can have that? I don't know if you know that answer to that question, but...
No, absolutely. I know the answer to this question. So there's two different options. And so when we're talking about women, she does have an option to do egg retrieval, egg harvesting, if she would like to absolutely preserve fertility, and then knowing that that's later an option. And for cancer patients, there's lots of opportunities and different grants and different support, but also knowing where to look for that, right? And being able to be in a comprehensive center where you have social workers and other people that can help us get those resources. But, that's kind of expensive in itself, right? For women, that's a very expensive procedure, and it takes time. That is a procedure that takes time. And sometimes when what we're all talking about, it feels like the patients don't have time. And so the medication, I can give a medication once a month, a shot. And this shot, essentially, if a woman is premenopausal, and I mean, even a 40-year-old woman, I would still want to give her this shot because I don't want chemotherapy or any type of therapy to put her in an early menopause, because there are different things that happen to women's bodies after menopause. Like, I don't want her to suffer from bone issues. I don't want her to have, a bad sex life. I don't want these things for her, especially if we're going to get rid of this tumor. So a medication is also something that we can give our patients. For men, what I always try to encourage, especially the younger the man, is sperm banking. And thank goodness for the Livestrong Foundation. It is very fast, and the grant support is very quick. And so having sperm banking available for young men or just men is also important.
Dr. Jones always continuing to educate me on how to best take care of our patients in this way. But this is so important because I think sometimes we say, so it's like, we see tumor, let's get it out, let's get rid of it. And then you think about all those other things, like a person's, for example, their sex life, their ability to have kids, the not wanting to feel like you're in Houston summer 24/7 because you're dying of hot flashes.
Right. Well said.
And just to know that all that information is out there through your social workers and through your local, your oncologist, and just to know to ask that, I think, is one of the most important reasons to do these multidisciplinary sessions, to find out where we can get access to it.
It's a good conversation to have, because the more people we cure, the more reasons to have these conversations. If we're able to help people live so long, how can we make sure their life is better?
Absolutely.
And so I don't know how you feel about it, Dr. Ho, but I mean, all the work that you're doing, especially surgically, right, for these very large tumors, and all the work that I'm doing in terms of the medications and making sure that they don't have these terrible side effects, we're able to cure so much more people.
Yeah, absolutely. But I mean, the reality is sarcoma, I mean, back in the day before we knew anything about sarcoma, again, I think the mindset in medicine
initially was like, okay, it's not a heart, it's not a lung, it's not a brain, whatever. You got a tumor, your leg, just get rid of it, So back in the day, people would just get amputation. You got rid of the tumor, done, right? But then people would still die from the disease. And that's because of the micrometastases that you're talking about, the cells that you don't see. So, honestly, surgically, not much really has changed that much surgically with what we do, So,
well, I think what I took for granted, Dr. Ho, was that you did a lot of limb preservation if you could. And I don't think I realized how special that was until I saw how other places, other surgeons were working with it and they were still doing amputations. And so knowing that these patients got to have their limbs at the same time, removing that tumor is important because that's the best way to make sure it can't come back. So for those people where it doesn't come back, that's really important. I appreciate your hard work.
Yeah, it's true. So people don't have lives after cancer. So I think it's really important to have knowledge and to figure out and help patients figure out where they need to go, that all that information is out there and accessible. And also, to back beyond that, we're talking about treatments, right? There's going to be the person who is young who may not want a big scar. There's going to be the people who need bigger surgeries, right, to take out sarcomas. There's going to be young patients that maybe may want to consider an embolization. So I think all these things, actually considering patient factors, even when you're formulating the initial treatment, is very important. So I'm so glad that you brought that up. All right, so moving on from desmoid tumor, soft tissue sarcomas, let's talk about osseous sarcomas. So, we biopsy those. A lot of times those tend to be big surgeries. Sometimes, though, they're metastatic. So we're talking about trying to do patient-centered care, correct? And when we're doing that, there's, chemotherapy involved. There's initially sometimes some big surgeries, Dr. Ho, but sometimes, there's quite a bit of metastatic disease. So when you have recurrent cancers or metastatic disease, how do you manage those? And then in a multidisciplinary setting, how do you involve others around you to help best manage patient symptoms and their cancer?
Yeah, absolutely. Well, this is definitely where, I work with Dr. Jones.
I know, I was just thinking, take it away, Dr. Ho, take it away. And me.
Yeah, and definitely on Dr. Levey. Really, in multiply metastatic disease, then we're, unfortunately, usually we're in a situation where we're not, our cure is not really feasible. If that's the case, then surgery is less of a significant, plays a less significant role. So for pain palliation, absolutely interventional radiology, of course, if there's other chemotherapy options, which is why, I always rely on oncologists as well. But absolutely, we always engage interventional radiology as well.
And that reminds me, like you were just saying, we need to treat the whole body and the cancers throughout the whole body. And we think, of course, about medication that's going to get through the whole body, which for the sake of this podcast, we're going to use the word chemo, but there are different therapies. There's targeted therapies, there's immunotherapies, and so on. But what is so important is thinking about outside of that box, thinking outside of just what can I prescribe as a medication. There are other ways that we can take care of things, again, that I learned only through taking care of sarcoma patients with you guys, where we can step away from the medications that are sedating our patient, right? I don't want her to sleep or him to sleep 12 hours a day. But not all departments are built the same, right? Not all radiologists can do all the same things, but what can we do locally to alleviate some of that discomfort?
And I think it's very important to talk about. A very good point, Dr. Jones. So I think whenever we have metastatic disease everywhere and patients have, let's focus again on osseous sarcoma, metastatic to the bone, there's this dogma in general, and, just to give people opioids, because that's what we have access to. That's what's easy. Pain pumps were a thing for a while, and then they came out of favor. Now they're coming back into favor of microdosing. I strongly recommend getting patients involved in intrathecal pain pumps and pain therapy as soon as you can, because the earlier the better, to be honest with you. We forget about using radiation. Radiation can be very good to treat bone pain. We're talking about bone pain related to vertebral bodies. Radiation can take about 10 to 14 days, though, for relief to set in. And if you're worried about fracturing, it doesn't help with that. So if you have a good teammate, a good radiation oncologist you work with, you can do radiation. And then within about a week later, you can do that with kyphoplasty. The patient gets immediate pain relief. They get their tumor treated, and they also get stabilization. If they worry about those, for my colleagues out there who do RFA or do cryoablation in the spine, There's always a worry about those posterior tumors, about pushing them more posteriorly into the spinal canal, which if you do that and you don't get all the tumor, then that decreases the ability to get a higher radiation dose because they grade their radiation dose as it gets closer to the spinal cord. This is also something I've learned a lot from the radiation oncologists I've worked with on the multidisciplinary tumor board. So putting out a plug again for doing this. But that's why initially they may not want you to treat with RFA or cryoablation, because if you fail, then you're also taking away their treatment too. So collaborating and doing radiation for the pain and the treatment, but then getting more immediate pain relief from the kypho immediately after is things you can do.
We need to talk, though, about not every back surgeon is the same as a back, to be oncology trained is different, because there's a difference between somebody who's trained with onc, right? And I learned this working with Dr. Lador, right? There's a difference in the downtime and because we're thinking about goals differently.
Right. Absolutely. They'll do separation surgery, that kind of thing.
Exactly right. And some people actually do need to have a corpectomy for stabilization too, as well, right? If they're having any symptom of cord compression or anything else like that. And then also going back to the pain, if the pain, and this is a big thing that people don't understand about pain, so pain can be mechanical, meaning it has to do with weight bearing. Pain can be nociceptive due to all the different signals a tumor is sending off to your body and all the different interleukins that are getting produced. The IR kind of jumps in, and it's really important to know your colleagues and who can manage these as well. And actually not just any orthopedic surgeon, an orthopedic surgical oncologist is the person you really need. So is the pain only mechanical, meaning it's with weight bearing? Would a nail just fix it if it's metastatic to the leg? Is it nociceptive as well, which means it's sending off all these different signals, interleukins, other things that are causing a lot of inflammation, and other ways to cause pain other than just neuropathic pain, which is made by nerves. So you have to figure out what type of pain it is that's actually causing the patient's pain, and then decide if you need multidisciplinary management. A lot of times when it comes to metastatic sarcomas or metastatic tumor to bone in general, it tends to be a combination of all of it. In general, though, nociceptive and mechanical at least. So really important to know that, you can do focal palliative cryoablation of these lesions, but what it does is it weakens the bone. I mean, as you guys see, as soon as you ablate or dig out any kind of tumor, it weakens the bone, so it needs to be strengthened. Otherwise, they're going to walk on it, they're going to fracture. So whenever you're looking and treating these patients in any setting, yes, you can help them if they have focal pain somewhere, but know that you also need to collaborate with somebody like Dr. Ho so that you can freeze to get rid of the nociceptive pain, but that bone's ultimately going to fracture and already has microfracturing in it, so they're going to need a nail. So very important in terms of pain management, in terms of doing something other than opioids, the bridge between the surgeon and the interventionalist. And also still, there is always going to be a role for opioids, but de-escalating them so the patient isn't in bed all day, so that they're able to drive, so that they're able to function is really what I would think the goal is. I don't know if you guys have any thoughts on that. I just said a lot.
No, oh my gosh, because Alexa, you're taking the words out of, I think, both of our mouths.
I'm just looking at nothing else to add. That's
I know, I'm looking at Dr. Ho and I'm like, I have this metastatic patient and I want to help you live as long as possible, but I want you to have the best life possible. And I want you to be awake for it. And if there's a way that there's to step away from medication, then let's do it. But more importantly, we need to know there's options. I didn't even know about a lot of these options until I was working with, this team, seeing that there were different ways to treat pain. There's different ways to do it. And thank goodness for all these advances, especially in interventional radiology. Because when we do those procedures, I'm able to give medication very quickly afterwards to control cancer.
No, I love that. And then in terms of pain too, sometimes, again, we can do focal metastectomy is what I like to call it, with the help of a surgeon for fixation if it's involving a bone. Sometimes if it's in the spine, we may be able to do radiation as long with a kyphoplasty for immediate pain relief. Sometimes though, if there's cord compression, you really do need to get a surgeon involved. And with that, sometimes it's choosing the right surgeon, correct? Because I don't think, like you were talking about earlier, Dr. Ho, not all orthopedic surgeons are the same, orthopedic surgical oncologists. And I imagine the way they manage a metastatic disease of anything, in particular, some kind of sarcoma involving the bone, may be different than a general surgeon.
Yeah, absolutely. There's a lot of nuance to treatment, right? So, I know maybe less so with sarcoma than other types of metastatic disease to bone, but, oftentimes what they call separation surgery plays a role. I'm probably not the best person to talk about it because I'm not a spine surgeon, but, in order to provide better, ability to deliver radiation, I think people hesitate to use the term debulk, but if the tumor's too close to the spinal cord, then they're not going to be able to radiate very well without damaging the spinal cord. So they will do surgery to kind of, give them space basically to give radiation. So absolutely, it's very important to have someone who's trained in tumor surgery specifically to weigh in on these types of cases.
Yeah. And I think you said taking a humble pill earlier too. It's very important to be able to talk with others, to be able to reach out to others, to say, I don't know, and to be able to give space for people who really have a lot of experience in this field and to allow yourself to grow. I see everybody nodding, which is good for the viewers out there. I really appreciate having both you guys on board to talk about such a very challenging group of tumors to manage, especially during Sarcoma Tumor Awareness Month, and for all your dedication to all of our patients all over. Any final thoughts or anything else you want to communicate to any of the other surgeons, the oncologists, the radiation oncologists, anybody else thinking about managing this difficult group of tumors?
Oh, I want to say something. I want to say that cancer treatment now is nothing like it was before. And it's because of our collaboration. It's because of advances in technology. It's because of these procedures and different ways of thinking and personalizing care. And it's understanding cancer at the level of DNA. And while sarcoma, we still have lots of room to grow. But knowing about genomics and learning about signatures and thinking about pathways, we are making better decisions. And so, yes, there are going to be cases where we may not be able to cure patients, but we can still help people live longer than we've ever helped them live before.
Yeah, absolutely. And I think, just to reinforce about collaboration, I mean, look, with what some people will say 100 or more types of sarcomas, I don't care how busy your center is, you're never going to get enough data in your center to make any educated decisions. It's only if we all really collaborate, we work together, we pool our data, and that we're going to really get anywhere else in treating sarcoma.
Everything's growing so much. Let me be the expert in cancer therapies and medications, and with everything that's growing. And I'm going to trust you to be the expert in your field too.
Wonderfully said. Wonderfully said. Well, guys, thank you so much for taking the time to be on here. I know we all have very, very busy, crazy lives, and it is truly a pleasure to be able to discuss this complex cancer management with two of the strongest females I know in the field, and I'm proud to call you colleagues and friends. So thank you for your time today.
Thanks so much.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junroy Kennebrew.
Thanks again, and see you next time.